Hello, it's Elizabeth. Let's take a look here at benign prostatic hyperplasia, or BPH. And let's start out with the patho. So the patho is that there is an increased number of cells of the prostate due to increased levels of dihydrotestosterone, and this is a common occurrence that just kind of happens with age. And because of this, we get an enlarging prostate that causes obstructive bladder symptoms. Obstructive bladder symptoms. So if we think about the bladder, it's up here, it holds our urine, and the urethra, before it kind of gets to the penis coming out of the bladder here in a male, we have the prostate, okay? And so the prostate kind of sits like a donut and wraps around the urethra as it passes through to come out of the body to go to the penis. And when that donut, the hole of the donut gets smaller and smaller, so this prostate's getting bigger and bigger, it kind of closes off the ability for the bladder to excrete urine. And that's where we get these obstructive symptoms in patients that have benign prostatic hyperplasia. So we get lower urinary tract symptoms, okay? And that includes urinary retention, urinary leaking, so we kind of have a leaky bladder here. And when we have this, retention, it leads to incontinence, which is an overflow and a dribbling. So our bladder is too full and it just can't hold anymore, so it kind of starts to spill over and little bits leak out. So the patients will complain of dribbling. And then they'll have the urinary retention that leads to increased risk for UTI because that urine's just sitting in there for excessive periods of time, and it's a warm, moist, dark place, and so things like to start growing. It is more common in African Americans, especially younger ages of African Americans. There can be a genetic susceptibility, and patients who have a family history of prostate cancer are more likely to develop benign prostatic hyperplasia, and also obesity plays a role. Okay, I've already given a little bit away about the assessment or symptoms, findings you might have in the patient with BPH, but they're going to have incomplete emptying of the bladder, which is going to cause frequency, and frequency just means I frequently need to go to the bathroom. So I'm having to go, every 5 minutes or something like that. Intermittency, so, we might have intermittency such as like I can urinate a little bit, and then I can't urinate, and then I can urinate a little bit, while they're kind of having their stream. Urgency, so I need to go right now, because if I don't go right now, I'm going to start urinating, and you will hear men say that in, the hospital sometimes that they have BPH. They'll say, I have to go right now. Like we can't wait a minute. A weak stream, so they have difficulty really pushing that urine out against the prostate, so they have a weak stream. They may have to strain to urinate, so they'll stand there. They're doing everything they can, kind of really pushing to try to get the urine out. Nocturia, so they may get up at night to use the bathroom, and then they may have post-void dribbling. So I already urinated, but now I'm dribbling, and it's because I didn't really actually empty my bladder, even though I thought I did. Hematuria is most commonly associated with an infection. So hematuria alone isn't really a symptom of BPH, but it's common for people who have BPH to have hematuria because they commonly develop urinary tract infections. And then mood swings. They could have mood swings because they have interrupted sleep. They may have a decreased libido. So, I'm having all these kind of urinary issues. Maybe I'm not as interested in intercourse as I once was. And then dribbling can lead to embarrassment. And then some tests. So a digital rectal exam. So this is where the doctor, or a nurse practitioner, or PA, whoever does a rectal exam with their finger And that helps to kind of, you reach in there and you can like palpate the prostate, you can feel the prostate, and you're just trying to see if it's enlarged. So that's a common test that might be done on a patient testing for BPH. A urinalysis, and this is really just going to rule out infection. It's not going to give us anything that's like, oh, they have BPH from their UA, but it's going to look for infection. And then we might do a culture also to look for infection. A CBC could alert us of signs of systemic infection, or if they're having severe hematuria, they may have anemia. I don't think that's probably very common, but I do suppose that could happen. Increases in BUN and creatinine would clue us into some kidney disease. And if we have, constant problems with emptying our bladder, this might lead to kidney problems, and we'll talk more about that. PSA is a test that we might do, prostate-specific antigen, and this test is really used to look for prostate cancer, but there is a mild increase in the PSA in BPH, but it's mild. If it's really high, we need to worry about prostate cancer, and that's a whole different thing. Transrectal urethral ultrasound. So transrectal just basically means we're going through the rectum to do this ultrasound to try to evaluate what's going on. Cystoscopy. Cysto means bladder, so this is a scope that goes in through the penis, through the urethra, up into the bladder to take a look around. And then post-void bladder ultrasound. And so you might have seen this if you worked as a tech or been in the hospital very much, but they do have these bedside ultrasounds that just test for, a bladder, how full your bladder is, like a bladder scanner, that type of thing. Commonly used. Okay, so some interventions. We have some behavioral modifications. Let's look and see what that is. So we want to recommend that our patient avoids drinking large amounts of fluid, especially at bedtime. So obviously they already have problems with nocturia, so we don't want them getting up all night long urinating. And if they drink a whole lot, they're going to have to pee a whole lot, and if they can't get the pee out, then that's an issue. Limit intake of caffeine and alcohol consumption. Both of these things have a diuretic effect, so they're going to cause the patient to urinate more, create more urine. And if they can't void, that's an issue. And then avoid drugs that cause urinary retention. So if you've learned anything about anticholinergics, those medications can cause urinary retention. And the mnemonic for anticholinergics is can't see, can't pee, can't spit, can't, you guessed it, S-H-I-T. So, anticholinergics, one of the side effects is can't pee, so we want to avoid that in these patients. And then antihistamines, they have an anticholinergic effect, so we'd want to avoid things like Benadryl. And then antipsychotics, those can also cause urinary retention, so we need these patients to avoid that. And some other interventions we have are some drug therapies. So we have the alpha-1 adrenergic antagonists, which is an alpha-1 blocker. And these relax smooth muscle in the bladder neck. And these have a side effect of a first dose effect, which means that this can cause, in the first dose especially, this can cause a low blood pressure. So this is actually, alpha-1 blockers are actually blood pressure medications. They're not super effective for blood pressure, so we really use them a lot for BPH symptoms. So the patient, the first time they take it, they may have orthostatic hypotension, so we want them to change position slowly, and maybe take it at bedtime, because that way if you're having orthostatic hypotension when you're sleeping, you're not going to have it because you're not going to be changing positions. Examples of this medication are tamsulosin, prazosin, and doxazosin. So it ends in osin. Then we have the 5-alpha reductase inhibitors, and these work to reduce prostate size. They may take up to 6 months to have an improvement in symptoms. So if my patient says, I've been taking my alpha reductase inhibitor, they might just call it finasteride. I've been taking my finasteride for, 2 weeks and I haven't noticed any symptoms. That might be expected because it may take longer for it to really work, have time to work to reduce the size of the prostate. These do have a teratogenic effect, so we don't want these to be around pregnant women, basically the pill itself. So like when you're popping those meds out at clinical, if you've got finasteride, you need to wear gloves, okay, because it's a teratogenic risk. So anybody of childbearing age. And then these medications are most effective when they're used together. So alpha-1 adrenergic plus 5-alpha reductase inhibitor. And we usually do that just kind of like later in the disease process after it's kind of been going on for quite a while. Complementary and integrative health. Going down here and talk about some of the other medications people use. Saw palmetto mainly is like the big one that you might see patients taking for prostate health. And it is considered a dietary supplement, so it is not regulated by the FDA, so use with caution. And there are just mixed studies as far as efficacy. So some things say it's effective, some things say it's not effective. So again, just use with caution. It does interact with NSAIDs and anticoagulants, so if my patient's taking an anticoagulant, they really probably should not be taking saw palmetto because it may interrupt the way that our anticoagulant works, and we don't want our patient to have too thin or too thick. Either way, we don't want that to happen. And then the saw palmetto can cause nausea and a headache, so those are some kind of expected side effects the patient might have. Non-surgical interventions and surgical management, and this is mainly to include a TURP, transurethral removal of the prostate. So for the TURP, an enlarged portion of the prostate is removed through an endoscopic instrument that goes through the penis and it goes through the urethra, and it removes prostate tissue in small pieces. Okay, so this goes in through the penis, and I got my prostate here that's kind of wrapped around my urethra, and this tube comes in through the penis and through the urethra, and it opens this urethra, and it scoops out some of this and pulls it out. Okay, and that just kind of makes that opening larger. So pre-op, we need to alleviate the patient's anxiety. Of course, they're going to be very worried. Anything to do with, your sexual organs is a little panicky. So we need to educate them on reproduction and sexual abilities following surgery. All anticoagulants should be discontinued a week prior. So this surgery that kind of has a high risk for bleeding, we definitely don't want them to be taking anticoagulants. Make sure they know that when they wake up from prostate resection surgery that they are going to probably have continuous bladder irrigation, and that it's going to make them feel like they need to urinate. Okay, so if you let them know ahead of time, hey, when you wake up, expect that this is going to happen, it's going to ease their fears when they wake up. And then it's normal for their urine to be blood tinged after the procedure. So let's just take a look here at this CBI, continuous bladder irrigation. So it has a really large bag of fluid hanging. Sometimes there's 2 bags. And this goes and connects to the Foley. They're going to have a Foley that has multiple ports on it. So this giant bag is going to connect to the Foley. The Foley goes into the bladder. This fluid's going to, you might have quite a bit of fluid going in there. It'll go in and kind of just keep this all diluted so that way blood clots don't form. And whenever the bladder, whenever it's in there, then by gravity it will drain out into the drainage bag. Okay, that's what continuous bladder irrigation looks like. Post-op care, that's your continuous bladder irrigation. They're going to have that. The nurse should maintain the flow of the fluid to keep the urine clear, like the fluid that's coming, back into the bag. So this might need to be titrated. So you might need to, open it up more if it's looking really clotted or that type of thing. But if it's clear, you might be able to turn it down and see if the patient can tolerate that. The bulb on the surgical urinary catheter is large. So the patient's going to have a continuous feeling of needing to urinate. Okay. Normal saline solution should be used. You don't want to put anything else in this bag. It's just giant bags of normal saline. You want to check the tubing for obstructions frequently. So if the patient is saying, I'm having a lot of belly pain, It might mean that they're having a bladder spasm because this tube that's going out into the bag is clogged with a blood clot, because this urethra might be bleeding quite a bit. So we need to figure out what we're going to do to relieve the obstruction, okay? And it may be that we have to unhook this and kind of push some saline in here, kind of like at a faster rate to try to flush it. But if we can't get it opened up, then we're going to have to let the surgeon know, okay? And monitor the patient closely if he's confused, because we don't want him to pull out his urinary catheter. Sometimes they do that, and that is quite traumatic, especially, we said this bulb is big. So it's larger than the normal 10 cc Foley catheter that you probably have used in the lab. Monitor the patient for signs and symptoms of infection. All right, we don't want him to get an infection. And so signs and symptoms of infection, fever, high white blood cell count, those are things that you could check for. And they're at risk for severe bleeding, so we need to monitor the urine output closely. So the urine output is calculated based on how much fluid's going in and then how much fluid is in this bag. So you would take how much is in this bag minus how much you put in, and that's how much urine they've created. So if they're having a large urine output and it's bright red, it might be that they're having a lot of bleeding, okay? And sometimes this says bright red bleeding with numerous clots. That could indicate arterial bleeding, which could be life-threatening, okay? You need to monitor the hemoglobin and hematocrit. If it's too low, that could mean our patient is having some serious bleeding. Okay, extreme cases for BPH. We're just back to BPH here. I know we were talking about the intervention of a TURP, but now we're just going to talk about BPH again. Urinary obstruction. So sometimes these men will come into the emergency room and they cannot pee. They can't pee at all. And so then urology has to come in and they have to dilate the urethra. And if you have not seen that, it looks like something of medieval times, and I promise you, you don't want to have it happen to you. So that's an extreme situation. I think it's fairly common. Sometimes we can go ahead and get a certain, like a special type of catheter in there, and that is called a coude catheter. And coude means elbow, so this is kind of like a curved tip on the tip of the catheter. Sometimes we can pass that through. And hopefully they wouldn't have to have that urethral dilation, because that is not pleasant. Another extreme situation that can happen is the patient can develop hydroureter, which can lead to hydronephrosis, and this can cause kidney damage. So if I have way too much urine in here and I can't get it out here because my prostate's obstructing, this urine's eventually going to start to back up into my ureter. And then hydro means water, so fluid. I've got fluid in my ureter, and once that gets to be pretty severe, this is going to back up into my kidney, and then I'm going to have hydronephrosis, and this could cause damage to my kidney that's not reversible. So we just really need to, monitor BUN creatinines, things like that. Some nursing diagnoses: urinary retention due to bladder outlet obstruction, and decreased self-esteem due to overflow incontinence. Okay, teaching. The ability to reproduce should not be affected by surgery. Okay, so if they have to have a TURP, they should still be able to reproduce, which might be something that they want or something that they don't want. And if they don't want that and they thought that that was going to happen from their surgery, it's just a good thing to just make sure they're aware. Either way, whatever they want, it's a good practice to just make them aware. So perform Kegel exercises. Some of you probably thought that was only for women, but men can perform Kegel exercises as well. And that helps to, this is an activity that you do to constrict and relax the sphincter frequently. Okay, and so how a man would do that is they would just do the same action as what they would do to start and stop a urinary stream. And that helps to develop that sphincter a little bit and improve the muscle control there. Loss of urinary control following TURP surgery is typically short-lived. So make sure they're aware that it's not like they're going to be incontinent forever. Are they sometimes? Maybe. But overall, we should give them a good outlook. It is usually a good outlook that they don't have ongoing incontinence. initially they may have some incontinence, and that's gonna worry them. So just reassure them that, you know, this is usually short-lived. Frequent sexual intercourse or ejaculation can reduce obstructive symptoms due to the release of prostatic fluid. So in your patient who hasn't had a TURP and they're having lower urinary tract obstructive symptoms, just ejaculation can help improve that overall. And then do not take over-the-counter medications that cause urinary retention. As we discussed earlier, antihistamines and decongestants, we need to avoid those. And then drink small amounts throughout the day. So that way we're just urinating small amounts at a time, and hopefully we can empty our bladder. Okay, folks, there you have it. There's your lesson on BPH. I hope you learned something. Thank you.